Florida, it is hot. Nearly didn't get in. There was big thunderstorms. They threatened to reroute me to Tampa.
Yeah.
It was very, very bad. Yeah. It's like 85 degrees and 100% humidity.
More than 1,000 flights were canceled yesterday, I heard.
Into Florida?
Yeah, all over the country, because there were thunderstorms at lots of different places, but more than 1,000 flights were canceled. Yeah.
Wow.
But it must be feeling like what, more than 100?
Yeah. When it's this humid, it feels pretty hot. Where are you?
I'm at Memphis. I'm at Memphis, Tennessee. It's pretty humid out here. The Mississippi River makes it really very humid and salty, but not too bad though. I mean, I've lived in Houston for a few years, and when I compare Houston and Memphis, Memphis is better. It's definitely better than Houston in terms of climate.
I know I trained in Houston as well. I trained at Baylor, and people think that Houston is dry. It is not. It is hot, humid, hurricanes. It's just like Bangkok. I'm Thai. It's just like Thailand.
Yeah. When were you at Baylor? I was at Baylor too. I'll tell you. I started there from June 2012, and I was there till 2015, late 14. Yeah.
Yeah, I trained there from 2004 to 2006.
Okay, got it. So that must have been probably a med school. I'm so sorry. I should have read your profile. I'm very, very sorry. But yeah, was that your med school then, or your?
That was my residency. Yeah.
But your residency. It has to be your residency. Okay, I'm sorry. Yeah. Residency. Okay. Yeah. Do you know Wayne Franklin by any chance? Wayne Franklin.
Boy, that name. Yes.
Yeah.
Tall black guy.
Tall black guy. Exactly. Yeah.
Tall black guy. Yeah. Where is he now?
So he was at Texas Children's Texas Heart for quite a long time, and then now he's at Arizona Children's Hospital. He's climbed up the food chain. He was the head of the adult congenital department at Texas Children's, but I think now he's at pretty high position at the Children's Hospital. Yeah.
Okay, so let's start today's program. I'm so happy that today's session is the last one. And in the past 2 days, we have a lot of topics and discussions. And today's topic are also exciting, including the minimizing the TAVR procedures, and the selection of TAVR valve, and the treatment of paravalvular leak. So this Dr. Yin will chair this session.
Hi, everyone. It's my great pleasure and honor to chair this session. The first talk will be delivered by Professor Li, and I would like to invite Professor Xiaodong to introduce Professor Li. Please, thank you.
Okay, good morning, everyone. And I'm Dr. Zhuang from First Affiliated Hospital of Sun-Yat-sen University. And the first speaker is also the team leader of TAVI in the First Affiliated Hospital of Sun-Yat-sen University. Professor Li will bring the topic, the valve selection in cardiologist's perspective. Please welcome Professor Li.
Okay, thank you, Dr. Zhuang and Dr. Wei and colleagues. It's my honor to be here to share my own perspective of TAVR or server from cardiologist perspective. Frankly speaking, we don't have so many TAVR experience comparing with yours, because we got TAVR valve only 5 years ago. That's the first Chinese-made domestic TAVR valve. And in the past 5 years, we have gradually accumulated our number. 3 years before we got a CPS valve, and last year the Evolut Pro valve also came into Chinese market. So my experience of all these valves is limited. So here I just share my own personal view as a young structural heart valve interventional cardiologist. How do I choose between TAVR or server? We all know in the past 2 decades is expanding or evolution for valve intervention. In 1989, the first animal experiment of TAVR was carried out, and in 2002, Dr. Prebier performed the first in-man TAVR procedure in the world. And in 2010, Professor Junbo performed the first TAVR case in China, in Shanghai. And the first domestic TAVR valve, the venous A system, was introduced commercially into the market in 2017. I heard last year there are over 5,000 to 6,000 implantations domestically in Chinese world, but the majority is self-expanding valve, Chinese own-made self-expanding valve. And also worldwide, with the introduction of TAVR procedure, there is accumulation in the evidence body, from the feasibility test to the extremely high risk group, the patient who cannot tolerate operation, to the patient who are high risk at operation, to moderate, to the low risk group. I think the game changer is the Partner 3 series, because it expands the TAVR indication from the former extremely high, moderate group to the generalized patient. Even the patient with low surgical risk can benefit from the minimal invasive TAVR procedure. I think the Partner 3 and Evolute low risk trial will be the game changer. Also, from these slides, you can see, according to all the accumulated evidence, both European and American cardiology societies and also Chinese doctors made their own recommendation regarding the TAVR procedures. Also, from the initial, the recommendation required to evaluate the surgical risk. If the patient was at STS risk score greater than 8%, we should send the patient with 10th, let the patient have a TAVR procedure. That's the initial recommendation. And later the indication expand to STS score greater than 4%. And nowadays, I think in the recent guidelines, the recommendations provide the patient more choice. I think the big change for the TAVR, for the selection between TAVR and the server is the surgical risk is no longer a major determinant. The guidelines recommended shared decision making. The interventional cardiologist and the cardiac thoracic surgeons will work as a hard team, balance the risk and benefit ratio, and decided the final treatment strategy. Here is a recent guideline recommendation. Also, our surgical colleagues had carried out some experiment to upstream to block the pathology cycle of aortic stenosis, which means when the patient is still asymptomatic, we can replace the valve early before they develop symptoms. We can benefit the patient. I think in the future, maybe for TAVR, we need or we will have the similar clinical trials for a symptomatic patient. We can TAVR the patient early before they develop symptoms. We can benefit them, and I'm pretty sure we could have a good result. So nowadays, a big change is we don't, in the guidelines, they don't list it, which patient should have TAVR, which patient should have a server. Instead, they said which factors this patient is more favorite to TAVR or more favorite to server, not absolutely a difference between TAVR and the server. So as a physician, let's come to what I learned from my past experience. I would start my presentation with this patient. It's a particular patient come to our hospital early this month. He was 59 years old male, and he's complaining of shortness of breath for 2 years. he is a heavy smoker. On echocardiography, we demonstrate the patient developed severe aortic stenosis. Echo revealed the aortic valve area is 0.8. The peak gradient is about 120 and mean gradient is about 75 millimeter mercury. So because he's a young gentleman and he is looks like his situation is not too bad. So I talked to him, you should have a aortic valve replacement. My first recommendation is go to our cardiothoracic surgeons. If they can replace a mechanical valve for you, you can carry this valve lifelong. But this patient said, okay, doctor, I want a high quality of life. I don't want to take warfarin every day. I don't want to check my INR every 1 or 2 weeks. So I want a TAVR procedure. So what should I decide for him? I just go TAVR him, or I just insist on him go to the surgeons. Here is my consideration. As a young doctor to do the TAVR procedure, the first thing I would like to think is whether I can perform this procedure safely and efficiently. The second thing is, if I can perform this procedure efficiently and safely, how long will this valve can work for this patient? Because this patient is very young. He's only 59 years old. On averagely, I can expect it. This patient might need another valve replacement, maybe in another 10 years, maybe 10 years or 15 years later, this patient needs the third procedure. So how long will this valve work for this patient? And what will happen when the next time the patient comes to me? That's my consideration. So as I speak, I mentioned before, I think Partner 3 trial is a game changer because it extends the indication of TAVR procedure to low risk group. Among the risk stratification, age is a very important factors. From Partner 3, you can see the 2 years mortality rate is almost identical between TAVR and the server system. And the Evolute low risk group demonstrate almost the same result. Regarding the short-term 30-day mortality and the 30-day major stroke rate, the result is almost quite similar. Although we lack of long-term follow-up result, maybe 5 years, 10 years, but based on the result from the Partner 1, Partner 2 trial, I believe in Partner 3, the long-term follow-up, the TAVR valve can work efficiently, safely comparing with the servo valve. So I think for working, put the patient TAVR valve is feasible. So are there any other determinant? So that what can I replace the valve safely? So the patient frailty is a very important factor for this patient. More severely patient more favors less invasive TAVR procedure. And here is other anatomical considerations we need to consider between we make the determination and including the access route, concomitant valve disease, coronary artery disease, and other factors. These factors we need to consider in choosing server or TAVR. For aortic valve anatomy, here are listed some factors. For severely calcified leaflet, maybe server is a better choice, especially when patient got calcified rough with excessive leaflet calcification, especially for those has a pure aortic stenosis. If the valve looks like that, you can imagine the patient might got a paravalvular leakage after you place a servo valve in. So because the patient has no regurgitation before, you fix one problem, you might cause another problem. Maybe for this patient, surgical valve replacement might be a better choice. The other thing is about LVOT calcification. Also, like the valve itself, severely calcified LVOT tends to be more favorite for surgical valve replacement. Conduction disturbance is another thing we need to consider. For patients with long membrane septum, the risk of conduction disturbance is relatively low. And also for this patient with pre-existing right bundle branch block, the conduction delay risk is very high. We all know that the conduction disturbance after the TAVR procedure is a predictor of poor prognosis. So we need to also consider the risk of conduction disturbance. And also the anatomy of the aortic complex, including the sinus valsalva height, the diameter of sinus valsalva, the coronary height, all of these can contribute to our final decision whether the TAVR system procedure can be safely performed. Peripheral access is another thing we need to consider. Although we have many alternative routes, such as axillary route, carotid route, and just the thoracic aortic route or transcaval route, but femoral route is still the most easy to use and the most safe ways. When make the decision, we need to consider the peripheral accesses, and which means whether I can use a very quick and easy way to fix the aortic valve. And also for some patients in Chinese population, especially in our Chinese mainland, bicuspid aortic valve is very common comparing with Western countries. A lot of patients with bicuspid aortic valve, they have concomitant aortopathy. For example, this patient might have aortic aneurysm. They have tortured ascending aorta or aortic arch. If the ascending aorta is enlarged, maybe the patient can benefit more from a bento procedure rather than just replace the aortic valve. Or if you choose the aortic valve, the short framed balloon expandable valve is better than the long framed self-expanding valve. And also for some patients, they have other valve disease. For example, the patient may suffer from mitral disease, may suffer from tricuspid valve disease. This might be difficult to decide whether the other valve is a result of aortic stenosis or is a concomitant valve disease. For example, I still remember very clearly, my first TAVI patient is only in his 50s. He was in severe mitral stenosis and he was in severe aortic stenosis with moderate aortic insufficiency, but also he has severe mitral regurgitation with severe pulmonary hypertension. He had ventricular tachycardia in the past 1 month, twice in the past 1 month. Our surgeon colleagues, initially I recommended the patient to do the aortic valve replacement plus mitral valve and tricuspid valve repair. But our surgeons refused this patient due to the high surgical risk. The main contributor to the high surgical risk is pulmonary hypertension. I was forced to perform TAVR procedure for this patient because he's only 55 years old. But lucky enough, we performed the procedure well. And after 2 months, the patient pulmonary hypertension almost disappeared. And the severe mitral insufficiency almost disappeared too. So for this patient, the primary lesion for this patient is aortic stenosis. And the mitral insufficiency and the pulmonary hypertension, tricuspid regurgitation is a result of severe aortic stenosis. Sometimes we cannot distinguish whether the mitral disease or the tricuspid valve disease is concomitant disease or the result of aortic stenosis. But anyway, if the patient has severely multiple valve disease, the better choice might be the aortic valve repair plus the other aortic valve replacement plus mitral or tricuspid valve repair if the or upon to the surgeon's decision. And for the young patient, I think the very important thing is to consider, because the patient might experience multiple procedures. So what should we do? Should we server, TAVR, or should we server, or should we TAVR for all for this patient? We need to do a whole life span management for this patient, because this patient will come to you maybe 10, 15 years later. These are some combinations of the available procedure. Frankly speaking, I don't think put server at the final step is a good choice, because when patient growing older, the risk for open chest surgery might comes to extremely high. So I think if you believe the patient have need to more than one procedure, put server at the beginning, or you just TAVR for all might be a better choice. This picture comes to last year's JCC intervention. The authors illustrated several combinations of available choice. We can server, TAVR, server, or TAVR for all. Looks like server, TAVR might be a good balance between the benefit and the risk. I think is still my favorite combinations. And also we need to consider is another very important thing. We need to consider is a future coronary access. Because the patient is still young, the incidence of coronary intervention in the future is very high. We need to decide whether the likelihood of the patient need coronary intervention in the future, and how the implanted valve can jeopardize the coronary access. But this problem is not easy to illustrate or to see. It's more personalized decision making based on the aortic valve, the native valve, and the implanted prosthesis. The configuration of the valve should be very difficult. I think for this kind of patient, we need discussion with our surgeon colleagues. Which valve is short, the pillar is shorter, which valve is bigger, I think is a more complex combination. So come back to my patient. Here is the aortic root anatomy of this patient. Looks like the annular is not so big. It's by diameter or by area. The valve is about 21 millimeter in diameter. And here is a sinus varsava, and here is the STJ. It's not severely calcified, but the calcification focused located mainly in the right cusp side, and also he has a very long aortic valve leaflet. From this picture, you can see the patient has a very high, might have a high risk for coronary occlusion of the left coronary, and both left coronary and right coronary, because although the coronary height is not too bad, it's about 10 for left and 16 for the right, but on the other hand, the leaflet is very long, and also the STJ is not so high, and the STJY is not so big. So if I put a TAVR case valve for this patient, there is a high chance I need to put a stent in the left main. Consider he's only 59 years old. In the future, if I want to do a coronary intervention, it will be very difficult to go through my device, through the windowing stent and into the native coronaries. And also maybe 10 or 15 years later, when the patient needed a second or even when he got older, I need a third implant valve. The chance of coronary jeopardize is extremely high. So that's my recommendation to this patient. My first choice is server with a mechanical valve if he accepted. Otherwise, I would like to suggest the patient, the doctor has a surgical valve with bioprosthesis, but the surgeons will cut the native valve and replace the valve with a short pillared valve. So in the future, I can do a TAVR in server or TAVR in server for the even long terms. So here is my perspective for the TAVR versus server. I think with the development of new generation TAVR valve, the durability becomes the main determinant for selecting TAVR versus server. As a young physician, when determining the TAVR or server, I will think, firstly, can I perform the procedure well or safely and efficiently? And secondly, how long will the patient live after I finish the procedure? Thirdly, if the valve was degenerated, can I repair or change it safely? And if future I need to stent the patient, can I safely or easily stent the patient across the implanted valve? I think if the engineer or the material scientist could make the valve lasting longer, for example, as a stent, like for lifelong, that will be finally totally change the game. Thank you for your attention.
Okay, thank you for Professor Lee to bring us the great topic here. So Professor Lin, should we bring the panelists to discuss this, or we save for all the talk after all the topic?
Yeah, we can allow one or two short questions.
Yeah, because for the TAVI and SAVI, this choice is quite complex. So Professor Lee bring us a lot of considerations, including the anatomy or the guideline recommendation. So if this young case happen in your center, how would you to choose to make a decision for the patient?
Professor Lee, are you gonna?
Sorry. This is my patient. So I strongly recommended the patient go to surgeons. Because if we forget the financial reasons, maybe a server with a short pillared aortic bioprosthesis is better. So in the future, I can access the coronary. That's I anticipate if we got bioprosthesis, maybe 10 years or 15 years later, I can put a CPIN within the artificial valve, and maybe another 15 years later, maybe I put another CPIN, or I put a self-expanding valve within the CPIN. I think that's my up to now. That's my combination: server, TAVR.
Okay, thank you, Professor Lee, for your excellent talk and informative review of the lifetime management of the patient. I think one of the advantage of TAVR is its simplicity and minimally invasive feature. I think it is a very attractive one for the patient, especially if the procedure can be finished and the patient can recover fast and discharge fast earlier. So the second talk would be TAVR at the same day discharge, delivered by Professor Mehul Patel. Dr. Patel is currently the chief of adult congenital heart disease, assistant professor of Michigan State University. He was trained in Mount Sinai and the Texas Heart. So I think he's the best person to deliver this talk. Please, Dr. Patel.
My honor, absolutely my honor to be here, to be invited. Thank you very much. The first talk was excellent. Thank you. And we have some points to discuss. I think we can discuss later on. I'm going to share my screen now. Can everyone see the screen?
Yes.
Okay, great. So thank you again. I'm going to be talking on the safety and the feasibility of same-day discharge after structural interventions, focusing on TAVR, but to include the entire structural gamut of interventions. I'm currently the Director of Structural Heart and Hybrid Lab at the Methodist Labona Healthcare, Germantown, Memphis, Tennessee. Here are my disclosures. So the standard of care for elective structural heart disease procedures have included at least one overnight hospital stay, what we call as a next day discharge. Same day discharge after PCI has been well studied with no difference in overall complications or repeat hospitalizations and cardiovascular outcomes. We published that on 2,500 patients earlier when I was at Mount Sinai. And since then, there have been a lot of publications on this. Same-day discharge after structural heart procedures, such as valve replacements and repairs, Watchman device implantations, are not well studied. Now, we certainly have some anecdotal reports. We certainly have some sites and some centers publishing only appendage occluders, only MitraClip, only TAVR, but the entire gamut with the complexity of structural heart interventions, there's not been a single site published that has presented a lot of evidence of same-day discharge and the protocols and all. So we assess the safety and feasibility of same-day discharge after transfemoral TAVR, along with alternate access TAVR, transcatheter edge-to-edge repair, transcatheter mitral valve replacement, Watchman device implantations, ASD and PFO closures, and selected patients. So if you have to look at some published data, William et al. And group discharged 56 patients on the same day after Watchman implantation. This is a single center data. Gillofer et al., they had 24 same-day discharge after Watchman implantation. Chen et al. Had 1 MitraClip discharge on the same day. Maraknikios had 112 Watchman implantations that were discharged on the same day. Tan et al. Had 72 Watchman patients discharged on the same day, but these were all multi-centric studies with more than 3 to 5 centers data combined together. Per Donson from Emory, they had 29 transfemoral TAVRs discharged on the same day and published. Russo et al., they had 3 transfemoral TAVRs discharged on the same day. And Rai et al., they had 6 transfemoral TAVRs discharged on the same day. Kapadia et al., from the Cleveland Clinic, they had 114 transfemoral only TAVRs discharged on the same day. We at our center here at Methodist Labona Healthcare, we have all in all 180 patients with same-day discharge. That includes transfemoral and alternate access TAVRs, which includes valve valves, which includes balloon valve fractures. It includes MitraClips, TMVRs, valve valves, intentional valve fracture, Watchman device implantations, ASD and PFO occlusions. So a total of 180 patients undergoing elective structural heart interventions between July 2020 till June 2022 who opted to go home on the same day in view of the ongoing pandemic were included in the study. These patients had good social fabric. They met our center's safety protocol. They met the TVT registry requirements, the lab and the ambulation criteria. We assessed the demographic, safety, and the outcomes. So this all stemmed from necessity because we are a medium volume program, and the volume at our center was getting affected with the pandemic. So we had multiple process improvement meetings with the administrative leaders, nursing leadership, quality and safety, and the reimbursement specialist. We planned on getting timely post-procedure echo to meet all the registry requirements. And we mapped the patient flow in the hospital based on the hospital layout so that these patients who come for elective procedures, they are kept as isolated as possible from the hospital traffic. So patients would come from home, they would check in at the same day center, they would be seen by the anesthesiologist, they would be prepped, they would get an IV line, they would get an ART line. From here, they would be wheeled to the hybrid OR where they would get the procedure. From there, they would be wheeled to PACU where they would recover for about 2 to 3 hours. they would be transferred back to the same day center. And if there are labs, EKG, X-ray, echo, and if the safety protocol is met with all the things that we're going to talk about really very soon, and if they're ambulated very well, then they check out. Most importantly, these patients do not see the face of the hospital floor or the ICU. So this is how the study protocol was laid out. These have to be electively scheduled structural heart disease procedures. There needs to be some favorable pre-procedural criteria, and these include patients with good mental status. They should be fairly independent. They should follow instructions very well. They should have good hemodynamics with no significant conduction abnormalities, or they may already have a pre-existing permanent pacemaker. There should not be any major hematological conditions. There should not be any major allergies. They should be all well prepared with the use of incentive spirometer. In our structural heart disease clinic, which is housed by our structuralist, by our surgeon, everyone, we give incentive spirometer to everyone in the clinic, and we teach them how to do it really very well. And if they're not really very well prepped, then they are not in the favorable pre-procedural criteria and they'll be excluded. Coming to the favorable procedural criteria, patients should not have any excess site complications. They should not have any procedural complications. They should not have any major conduction disturbance requiring temporary pacing. There should not be any anesthesia-related complications. Talking about the favorable post-procedure criteria, these patients should not have any significant changes in labs. There should not be any significant changes in the EKG from baseline. They should have good valve and device function with no new regional wall motion abnormalities. There should not be any drop in the ejection fraction. There should not be any new effusion by transthoracic echo. They should all have a full recovery from anesthesia. They should be ambulated twice, first in the first 2 to 3 hours of the procedure and the second before discharge. They should all get a second dose of antibiotic before discharge. Most importantly, they must have a very good social fabric. They must have a good caregiver to stay overnight. They must have a fully charged and a working cell phone. They must have reliable transportation, and they must have the ability to get the prescribed medicines. If and only if all this is met, and if and only if the patient and the caregiver prefer to go home, only then they're eligible for same-day discharge. And this is what we strictly follow at our center. So the 180 patients, 61 underwent transfemoral TAVR, along with alternate access TAVR, including 2 Wallin valves, 1 balloon valve fracture, 2 transcarotid TAVRs, 1 subclavian TAVR, 2 BAVs, 15 mitral clips, 15 TMVRs, which included 1 balloon valve fracture as well for paravalvular leak that the patient had, which was at least moderate in nature, and the leak was completely obliterated by the balloon valve fracture. There were 75 patients who underwent Watchman implantations, and the remaining patients, 22, underwent ASD and PFO closures. The mean age was 75, ranging from 41 to 92 years, with men forming a majority. General anesthesia was used in 157 patients, conscious sedation in 22, and local anesthesia only in 1 patient. Event monitor was liberally used for TAVR patients to monitor for any degree of QRS or PR prolongation from baseline. Those with any degree of baseline right bundle branch block did not go home on the same day. Mean contrast usage was 80 ml of Visipake, ranging from 0 contrast to 200 ml. The mean procedural time was 32 minutes, ranging from 14 minutes to 121 minutes. The mean length of stay was 8.1 hours, ranging from 3 hours, as short as 3 hours after Watchman, to 16.8 hours. 16.8 hours were the first few patients that we watched for a little longer time. So that's the reason our range is really very wide. On an average, our TAVR patients go home in 4 to 6 hours. Our Watchmans go home in 3 to 4 hours. Our PFO patients go home in 3 to 4 hours. Even our mitral clip patients go home in 3 to 4 hours. All patients receive a cell phone to call in case of any concerns and for easy access. All patients received a call in the evening on the same day and on the next day morning. There were no readmissions, bleeding episodes, acute kidney injuries, or deaths till the first in-person 1-month follow-up. So to conclude, selective same-day discharge after transfemoral TAVR, along with alternate access TAVR, TEER, transcatheter mitral valve replacement after valve replacements, Watchman device implantations, ASD, PFO closures is safe and feasible and may be considered in patients who opt for it and have a very good social fabric. This is the largest spectrum of same-day discharge after structural heart disease intervention presented till date. None of our patients entered the hospital floor or the ICU. Same-day discharge improves patient satisfaction and increases hospital bed availability, importantly in the ongoing pandemic. And it has an enormous potential to reduce overall healthcare cost globally. Thank you.
Well, it's really amazing, I would say that. Because these are highly selective patients, do you routinely to shorten the hospital stay, saying in those who with a conduction disturbance, will you shorten the observation time? Because we do have some patient needed pacer maybe 10 days later, or develop a delayed coronary occlusion, such delayed vascular bleeding, such complications. What's your opinion on this?
Absolutely. So our ratio of same day versus next day is about 25 to 30%. So we are very, very selective. And actually, I had a presentation ready about the need for permanent pacemaker implantation after TAVR. And there's more and more evidence that has been shown now that right bundle branch block, we all know it's a high risk for getting a permanent pacemaker after TAVR. But even left bundle branch block. So the predictors for immediate need for pacemaker are right bundle branch block. But the predictors for late, now what is late? It's not well defined, but there are lots of papers that are pouring in right now. But relatively, it's about 7 to 10 days. The predictors for late pacemakers are left bundle branch block. So 11% of patients with left bundle branch block end up getting a pacemaker within a year. That's pooling of all the data. I've done a meta-analysis. I'm about to publish that later. But 11% of patients with left bundle branch block get a pacemaker within a year. And even atrial fibrillation is not benign. Those with just atrial fibrillation, they are at risk of having a pacemaker also. And AFib and left bundle branch block, those are predictors for late requirement for pacemaker. Right bundle is a risk factor for immediate need for pacemaker. But we screen all that very, very carefully. And if we find that there's any evidence of any right force or any right bundle branch block, however small it may be, we don't send them home on the same day by any means. Left bundles, pre-existing left bundles, we are carefully sending them home with an event monitor. Of course, anybody with a QRS of more than 120, we make sure that they go home on an event monitor. If there's any QRS broadening of more than 20 milliseconds from baseline, we don't send them. We're very, very careful, yeah.
How about using the remote monitoring of the EKG?
Yes, the same thing, sir. We do the 30-day event monitor. That's actually remotely monitored. So it's actually the transmission is beat to beat, second to second, and it relays through a satellite system onto the company. And if there's any drop in any beat, if there's any pause or something, they are notified instantly. And whoever's on call in our team, they are notified in less than a minute. Yeah.
Okay. Thank you very much.
Thank you very much. Thank you.
Yeah. I would like to invite Professor Tang Yida to introduce the next speaker. Tang Yida is not available. Okay, the next talk will be delivered by Dr. Xianbao from Second Affiliate Hospital of Zhejiang University. He's also a main implanter in China. I think the Zhejiang have their experience in minimalist approach for TAVR. Professor Liu, please.
Thank you, Professor Ying. Can I use Chinese for the presentation?
Sure.
Okay.
The slide is in English.
Okay. 尊敬的魏院长，还有我们殷院长，还有我们其他线上的各位专家、各位同道，大家上午好！非常感谢，大会邀请我们来参加这么一个非常成功的高大上的一个会议啊。这个前面2天也都是参与了，因为整个会议我觉得我们学习到很多东西。这了我们团队呢也非常感谢你们信任我们参与了很多的内容。那接下来我代表我的老师王坚教授，也代表我们团队跟大家一起来汇报一下这个我们自己中心在一些尝试的一个的 Minimalist TAVR 当中的一些工作。那应该说这个 TAVR 大家前面都提到了，循证依序都很足，无论是不同危险分层、不同的器械都取得很好的研究，所以指南也做了一些更新，一些以这个年龄包括解剖的结构、患者的意向为导向，欧美都比较一致。但确实作为这个 traditional TAVR 跟 Minimalist TAVR， 应该说 Minimalist TAVR 应该一定是个未来发展的一个趋势，所以现在目前国内越来越多的中心也来尝试。那我们中心呢也是在王书记的领导之下啊，选择一些这个择期的病情稳定的患者，这个来做这样的一些手术。那么确实我们前期也查阅了一些资料啊，包括我们主要是根据一些 3M 的一些参考，那对于稳定的择期的筋骨动脉途径的这个 TAVR， 那我们也会采取类似的一些做法。那个王书记呢，因为前面在大陆做啊，实际上我们应该说由于器械的限制，包括一些理念等等，应该说其实大家都是做得很常规的，做的相对来讲比较复杂。那我们中心虽然说王书记的理念比较好，比较新，我们虽然说整个过程做的其实还是比较简略，但是呢我们在出院上还是比较保守，比较一般来说总是手术以后5到7天才能出院。所以那2020年初开始，王书记要求我们还是要按照最新的标准实行一个 next day discharge。 所以当时其实怎么说呢，回想到2年以前，在我看来我觉得是不可以接受的，就是我觉得做不到，因为受到器械的限制，各方面条件的限制，觉得做不到。所以我们说有没有可能我提出来跟他讲，有没有可能分成2步走，先做到3天叫 early discharge， 那应该也已经是不容易了啊。原因有很多，找很多的借口，包括原来住院7天左右，或器械的原因，患者能不能接受，安不安全的，做完手术以后还是有一定比例的可能会出现发热啊、出血啊，尤其是需要装起搏器。所以对于这样的情况，那我们怎么来做？在王书记呢还是非常坚定 ，no excuse， 必须做下去。所以呢，就是他带领我们团队，就是多次头脑风暴，从流程上进行改进，从术前、术中、术后，包括长期随访等等，我们都是做了一些改进。所以到现在为止，应该说我们为了这个事情看起来很简单的，但实际上在我们目前大陆里边来讲，实施起来是非常困难的。所以我们开了超过100次类似的会，完善了相关的流程。而且流程呢，我们可以把它细化到每一个小时要干什么事儿，而且不光光是医生，还有护理团队，包括我们的随访人员都是要跟进来做这个事儿。有时候我们甚至在半夜3个晚上还要来跟进这个事儿。所以呢，我们先在王书记前面这个要求之下呢，我们也做了一些探索。首先我们选择了一个相对来讲比较简单的一个患者，70岁，这个生物瓣衰败的患者，这样对于估计传导不会有太多的问题。所以呢，我们给他做了一个很简略的，所以当时给他做了局麻浅镇静，不用舌道，只要临时起搏，通过股静脉做完以后就拔掉，也没有穿深静脉，就是留了一路外周的比较粗的一个静脉，做了有创血压监测，4个小时之内就把它拔掉。导尿管前面是放上去，手术以后即刻也就给它拔掉了。那通过这一例患者呢，应该说还是达到了我们预期的结果。4个小时以后，患者就下地走路，而且这个病人出院以后恢复各种情况都不错，1个月的随访也显示了很好的一个结果。但确实这个在整个操作的流程当中，第一例是很顺利，后面也不断的遇到问题，所以我们也是 PDCA。 那对于导尿管的问题，可能我们刚开始确实这个导尿管刚开始给它拔掉，然后后来有一部分病人排尿困难还得插回去，所以为了这个事儿我们也召开 PDCA， 到后来就制定流程。有些患者那我们是当场就拔掉，有些患者到病房里边拔掉，甚至第2天拔掉，有些患者我们就不查。但是最关键的问题 我觉得还是一个传导系统的问题。前面那个教授已经提到了，其实传导就因为尤其是我们目前大陆我们用的是这个自膨胀瓣膜比较多，这个传导系统的问题不解决，意味着这个患者的安全性就会难以保障。包括前面殷院长也提到的，10天左右再去装起搏器，那这个患者的安全性如何来保障？那我们刚开始的时候呢，我们也查阅文献，制定了相应的一些流程，就什么样的情况4个小时可以拔掉，什么样的情况保存到24小时，甚至要48小时，甚至要72小时，甚至我们要装起搏器等等。所以这个患者呢，我们前期根据我们的 protocol， 我们是第2天没有出院，延长到48个小时，这让他出院，这让回去第4天患者就出现了症状，再次回来装了起搏器。所以这个事情呢，其实给我们一个警示，实际上我们的流程还是有问题，所以我们不能简单的靠查阅文献就能解决所有的问题。所以呢，我们以此为契机，又再次查阅相应的一些文献，这要根据我们自己的一些情况制定相应的流程。所以呢，我们有时候把48小时会延长到3到5天，尤其是合并房颤的病人，这样的病人实际上跟这个普通的其他的病人不一样。所以包括我们建立了非常有效的及时的沟通机制，所以有时候晚上可能我们做到6、7点钟、7、8点钟，4个小时以后就晚上半夜了。对这样的病人，其实我们随访的团队都是无怨无悔的在做这个事儿啊，也只能是这样才能保证这个安全。那话又说回来，光靠劳力的投入不行，我们还是需要用科学的手段来做这个事儿。所以呢，我们还是跟华为公司合作，用最新款的华为的这个手表，它带有心电记录功能，那我们就来监测 TAVR 术后这个传导组织的一些情况。所以呢，我们也建立了一个叫这个 Smart TAVR 研究，也在 Clinical Trial 上进行了一个注册。那我们可以看到，这个华为实际上很先进，它客人不舒服了，马上按一下，心电图出来，我们都比对过，对吧？做过确证性的一些验证，跟我们做出来12导的心电图还是比较类似的，只不过它是单导而已。那我们做了一个前瞻性的一个队列性的研究，我们都规定好，术前1天测2次，术后第1个礼拜每天测2次，术后2到4周每周2天，每日2次，后面在1年之内每周选1日测2次，而且我们设立了这个临床事件委员会和数据安全的监察委员会来监察。那我们把2020年7月份正式开始这个项目，到2021年7月份，也就是1年的时间，我们入组了总共150例符合要求的患者。那我们来看看他的一些数据，平均年龄在我们中心入组的是73岁，那么 STS score 是 3.85%， 那应该说属于低危为主的病人，合并症跟其他的研究没有太多的一些区别。那右树枝传导阻滞是达到了 7.5%， 那应该是右树枝起搏右树枝的传导阻滞它是引起起搏器植入的一个独立的危险因子，那确实发生的概率也不低啊，我们可以看到 7.5%， 那应该是对我们整个研究也会产生一定的影响。自膨胀瓣膜用的 91.3%， 这个因为是大陆国产的很多的瓣膜是 91.3%， Saving 3用的是 8.7%。 那从在 in hospital outcome 里边我们可以看到，这个 mortality 是 0%， 起搏器植入率是 7.3%。 那么虽然前期我们觉得这个任务很难完成啊，那个包括说这个 next discharge， 包括有些人他一定不出院，包括我们礼拜5做了5个病人，实际上有3个病人是可以出院的，但是有1个病人怎么说他就不出院，他坚决不出院，那有时候我们也没办法把这些所有的记录在里边。我们 next discharge 达到了 60% 左右， early discharge 达到了 85%， 所以呢应该说只能说是取得了阶段性的成果。那么确实离目前国际上做的最好的，包括刚刚讲的 same day discharge， 应该说还是有一定的距离。这不光光是器械的改进，还有手术结果的改进，当然还有一些理念的一些改进，包括我们医生的理念、患者和家属的理念等等，需要综合整个体系的改进才可以做得到。确实我们也通过这个 Smart TAVR 研究，我们可以看到它这个传导阻滞你看一下往左，术后到1个礼拜是上升的过程，后面是逐步下降的过程，到了4个礼拜的时候只有 19% 左右。那么3度房室传导阻滞需要装起搏器的，也是在住院期间发生最多的，后续有没有？还是有的，不是说没有啊。所以说应该还是说，包括我们有6个病人最后还是回来装了起搏器啊。所以我们可以看到30天的随访结果， 这个 mortality 还是0%， stroke 有一例0.7%。这个 rehospitalization 就是因为有一些患者因为传导系统我们及时发现了有不舒服，马上后台看，或者每天或者没有不舒服，我们就已经发现了，主动打电话把他叫回来。所以起搏器植入率从 7.3% 到了 11.3%， 所以说确实还是自膨胀瓣膜会更高一些。那么包括这个手表还有其他的一些功能，包括对于心率，包括活动量、血氧饱和度等等都是做了相应的监测。应该说这个研究呢到目前为止是全球第一个用智能手表可穿戴设备去做的。所以呢就是我们当时2021年把它投到了这个 ACC 的一个摘要上，100例的数据投过去，他们也很感兴趣啊。最后我们的全文是发表在 JAHA 上。再另外呢就是我们也有一些比较好的一些 case， 包括传导系统的发现，包括有些患者有胸闷，我们做了以后发现这有改变的，到当地医院去做造影，有缺血事件，放了支架的等等。所以应该说可穿戴设备对于 TAVR 术后有一些早期出院的患者，应该说对于这样的病人的管理来讲是一个提供了一个新的一个方式。就包括我们这个极简式的 TAVR， 包括我们的我们这个整个项目对于90岁以上的患者来讲也可以做到 next discharge 啊。所以应该说还是只要技术包括器械包括理念跟得上，实际上一切皆有可能的。所以最后我觉得这个项目应该说在王书记领导之下，他敢想，团队敢做，而且一定是组建一个最优化的团队，包括年轻医生、护理、随访，一定是很坚定的把这个事情给做好，一定能做得到。所以说只有想不到，没有做不到，一切皆有可能性。所以最后做一个小结，就是 TAVR 应该说目前还是非常的安全有效，接见式 TAVR 也是安全可行，但话又说回来，一定是要经过综合的评估，选择合适的患者，而且这其中一定是个 team， 非常重要，就光靠一个人不行，光靠医生也不行，还需要靠护士、随访人员，还要靠患者自己，还要靠家属，整个体系的改变才能保证这个 TAVR 推广到更多的患者。而且同时我们要结合一些先进的一些手段结合在一起，这样才能够让更多的患者能够享受到高科技所带来的红利。好，这就是我的汇报，谢谢大家。
Yeah, thank you very much, Professor Liu, for your excellent talk. I think telemonitoring is a key methodology to identify those patients at high risk of conduction disturbance. We have also done a study, only 50 patients with continuous 7 to 14 days EKG monitoring for every single beat. And we do found 3 cases of them needing delay pacemaker implantation for conduction disturbance. So almost the same as you have found. I think this would be the issue in those patients, those hospitals with high workflow. Thank you.
Thank you, Professor Ying. Thank you very much.
Okay, the next talk will be chaired by Professor Chong-Chao. Please.
Okay. The next speaker is Dr. Yung-Tsai. Dr. Yung-Tsai is my mentor. He taught me the TAVI procedure, and he's expert from Zheng Hospital, Taiwan. Today's talk is management of paravalvular post-TAVR. Please.
Good morning. I am Yung-Tsai. Today, my topic is on management of paravalvular leakage after TAVR. More than moderate para immediate after TAVR cause no cardiac output, respiratory failure, and increased since 30-day mortality. Sometimes patients tolerate at the initial stage. However, more than moderate para increase the rehospitalization rate significantly and even cause long-term mortality. There are several methods to check the severity of para, and this is an illustration of AR index less than 25 increase the mortality rate after TAVR. Echocardiography and could check the paravalvular leakage. So let more than 10% circumferential paravalvular leakage is called moderate paravalvular leakage, and the implanter should focus on how to treat that. Here I show some cases to treat the paravalvular leakage. First is TAVR in TAVR. This is a case of pure aortic irritation. At that time, we only have the core valve system. And after deployment, the valve diving into the left ventricle, and we use the core valve in core valve to solve the problem. After core valve in core valve, only mild paravalvular leakage noted. And at that moment, we did not know much about the VTC or how to solve the problem. And this is another case of core valve in core valve. And after implantation, usually have some paravalvular leakage because the waist cannot seal the annulus completely. And this is bicuspid aortic valve patient with heavy calcify. You can see here the valve diving into the left ventricle, and the implantation depth is around 12 millimeter. After a couple months, the patient readmitted to hospital because of severe heart failure, and the implantation depth become 15. Because we all know the valve, we are self-spending maybe for 6 minutes or 1 or 2 days. So the valve will become diving into left ventricle after index procedure. So at that moment, we use a SAPIEN XT to further dilate the core valve, and there were no paravalvular leakage after the procedure. We can also use the occulter to solve the paravalvular leakage. This is a patient with bicuspid aortic valve received CABG before this disease, and this heavy calcified prevent valve further dilation. We use S3. You can see when S3 implant, the valve can touch the aortic wall, and this side calcification cannot push anymore. Because of the valve touch the aortic wall, we did not do any further post-dilate, and the post-angio show moderate paravalvular leakage. After 6 months, the patient readmitted to hospital because of heart failure. The T show here is severe paravalvular leakage and with 2 jets. We use a VP2 to solve the problem, and this is the first VP2 occurred, the largest one. And finally, 2 VP2 over here solve the problem, and the patient did not admitted to hospital anymore. And sometimes we could use the snail to solve the problem because the valve did dive into the left ventricle. This is a patient with aortic stenosis. The multi-slide CT show only mild calcification. After several times of releasing and retrieval, the fourth time releasing, the valve dive into the left ventricle. You can see here the valve was diving into the left ventricle, and that's caused a problem. So the post-angio here is moderate paravalvular leakage. So we use a balloon to dilate further, and the paravalvular leakage is still. Now the T show here is supravalvular leakage and the paravalvular leakage. And the cause in the mitral valve function is sometimes a little bit affected, so the valve did not open quite well. We use 2 snares to pull the marker, the C marker of the elbow root. So gently pull 2 to 3 millimeter up. The final only mild paravalvular leakage, and we check TEE again. The mitral valve function improved, and only 2 small jet over here. So we stopped the procedure, and the patient did not have pacemaker after the procedure. When valve dive into the left ventricle, the paravalvular leakage becomes supravalvular leakage. And here you can show the annulus have a gap over here. And sometimes it's too deep. The mitral opening the mitral inflow was affected. So this caused the mitral regurgitation and the stenosis. If this condition happen, you should solve immediately, or the patient cannot leave the operation room, or even the patient leave the operation room, he will come back very rapidly because of the mitral regurgitation and the aortic regurgitation. And in this index case, as you can see, severe paravalvular leakage and the supravalvular leakage. So the pace was snare up the valve. However, when you use the snare, you should watch. If you pull too hard, the valve will pop out, just like the opening champagne. So this is my last slide. To have the moderate paravalvular leakage, it causes acute hemodynamic deterioration. If patient tolerant initial stage, just heart failure and the cardiac test may cause the long-term effect. To treatment of the moderate paravalvular leakage, valve valve may be a solution, but you should know the design of the valve and the etiology of the valve function, the etiology of paravalvular leakage. And the implanter should aware about the mitral valve function and the virtual coronary valve to coronary distance, because the valve in valve might cause the sinus circulation. Sometimes you can use occluder. However, in self-expanding valve, the access of occluder got very difficult because sometimes the commissural alignment is a problem. So it can take time to implant occluder when you use the self-expanding valve. And finally, you can use the snare to pull up the valve and let the valve in the correct position. Thank you for your attention.
Thank you for your excellent talk. I have a question. Do you have any recommendation of the occluder based on the size of the regurgitation or?
Yes. If the patient have the moderate paravalvular leakage, we should do a 4D CT, because the 4D CT can check the area and the site of paravalvular leakage. Such as in my third case, a heavy calcified patient, after stepping, there are 2 holes over there, and you can check the multi-site CT and consider what kind of the occluder can use. And you should use the TEE to measure the orifice of the paravalvular leakage. Combine the TEE and the CT measurement, and you can assess the paravalvular leakage, and you can implant the occluder. Because the most TEE person, when they taught you the position of the paravalvular leakage, sometimes if he did not think about the direction of the TEE guide and the implanter, it should be in the opposite position. So if you check the multi-slide CT and the TE at the same time, and you can get a very good orientation when you implant the paravalvular VP2 or the other kind of the occluder. So it is very important that the TE and the TE guide the occluder therapy. However, before this occluded therapy, you should do a body CT to check which position is most important.
Thank you. The second question is any hemolysis developed after the occluded implantation?
I think as from the such parabolic after surgical back is always cause the hemolysis, and I have saw 2 cases of the deep diving valve and the hemolysis. However, after pulling up, the hemolysis improved, and in our center we did not check this is quite openly. However, that's in the NTUH study, they say that some patients still have some very tiny hemolysis. I think that the hemolysis is not as severe as the surgical heart valve. However, you should watch the hemoglobin.
Thank you. Is there any comment from the panelists?
Yeah, to our experience, for balloon expandable valve, you can overfill 1 or 2 cc to further dilate the valve if the paralysis was purely para instead of valvular leak. That can reduce the size of paralysis of less than 3 millimeter to insignificant or none. But for those patients with paralysis more than 3 millimeter in size, usually you may need an occluder. Depends on the symptom of the patient. Does the patient have a heart failure or hemolysis?
Thank you.
Okay, let's move to the last talk of this session. This talk will be entitled Valve Selection in Surgeon's Perspective, which will be delivered by Dr. Chris Malaisrie. He's a professor of surgery in the direction of cardiac surgery at Northwest University and attending cardiac surgeon at Northwest Medicine. His major in cardiovascular surgery, including the Marfan and the bicuspid and other, and the etc. etc. So I think as a surgeon, we are happy to have Dr. Malaisrie here and telling us what's the current surgeon's perspective in the era of TAVR. Thank you. Hi. Please turn on your microphone. Thank you. You're on the air.
Let me share my screen.
Sure.
And let's make sure that everyone can see.
Yes, we can see very well.
Okay. And we can see this screen still?
Sure, no problem.
Do you see the slides, Dr. Yin?
Yes, very well. You can start your talk. Yeah, no problem.
Okay, well, good. Thank you very much. My name is Chris Malaisrie. I'm a cardiac surgeon and professor of surgery at Northwestern. Thank you for the gracious introduction. And thank you, Dr. Yin, Dr. Wei, and Dr. Yi for inviting me again to the Taipei Valve Summit. And I've been asked to talk about valve selection and my perspective as a surgeon. And this is the overview of my talk. And I think the two most important points that people should get from this, because it's not only a perspective of me as a surgeon, but a perspective of a comprehensive aortic and valvular center. This is how we think about valve selection for aortic stenosis. And the first key point is when we talk about valve selection, there's actually two decisions that need to be made. The first is the valve choice. So what prosthesis is going to be chosen? And the second is the valve approach, whether you're going to do a sternotomy, TAVI, or minimally invasive heart surgery. So that's the first important point. Valve selection is two decisions that have to be made. And it's important that valve choice is the first decision to be made, because if we talk only about TAVI, we're talking only about biologic valves, and we rule out a lot of other important options that can be available to the patient. And for the surgeons that are watching, I'll have videos for both the Ross procedure and mini thoracotomy aortic valve replacement here. So let's start with valve choice and clinical practice guidelines that are recent and published. So these are valvular heart guidelines from America and from Europe. And the key feature for valve choice is age. So patients that are greater than 85 years of age should probably get a bioprosthetic valve. And this is in alignment with both Americans and European guidelines. For patients who are less than 50 years old, should probably get a mechanical valve. Europeans say less than 60 years old are also candidates for mechanical valves. So there's an in-between age between about 50 to 65 where clinical decision-making is important. And there's where these factors come into play. So what are the factors that favor mechanical valves? Well, I think the first thing is obviously patient preference as to whether or not they want to tolerate anticoagulation or they want to risk future re-intervention for structural valve disease. There's several other things that should be considered. Accelerated structural valve disease would favor mechanical valves. This includes young age, less than 40 years old, hyperparathyroidism, patients who are on hemodialysis. Other factors that would favor mechanical valve are if the patient is already on anticoagulation for another mechanical valve, or they're already on anticoagulation for venothromboembolism, atrial fibrillation, or any other sort of hemophilia. Patients who are expected to live for a very long time, that would also favor mechanical valve. And because the hemodynamics from most mechanical valves are better than bioprosthetic valves, small aortic root is also a consideration. On the other hand, these are the factors that favor biologic valves. Patient preference always comes number one, but patients who cannot tolerate anticoagulation, that's a class 1 recommendation to go to a biologic valve. If there's no anticoagulation, there can be no mechanical valve. If the patient already had a mechanical valve and requires reoperation, that patient should probably get a biologic valve the second time around. And women who are considering pregnancy and childbearing can opt to get a biologic valve during pregnancy through their childbearing years and then possibly get a mechanical valve afterwards. And also, if there is a low risk for future aortic valve replacement or TAVI. So valve choice is the most important decision, and it trumps the approach. And again, you'll see here, over 65 years of age should get a biologic valve. Patients less than 50 years old should get a mechanical valve. And the in-between age there requires clinical decision-making. It's a key feature there. What is often not discussed with patients is this option, the pulmonary autograft, so the Ross procedure. And this does show up in clinical practice guidelines. American guidelines state that patients who are less than 50 years old who would want a biologic option, is reasonable to offer these patients a Ross procedure. And for those who are unfamiliar with the Ross procedure, this procedure where on the left side, the valve is excised. After the valvectomy, the pulmonary artery graft is harvested and translocated into the aortic position. And in the space where the pulmonary valve used to exist, we put in a pulmonary homograft from a cadaver. There are two techniques that surgeons use to do the Ross procedure. The first is the original way that Sir Donald Ross performed this operation, is as a subcoronary technique. So the buttons are not excised. The autograft is sewn in a subcoronary position. What's more favored now is the full root technique shown on the right. This requires coronary mobilization, implantation of the autograft as a root, and reimplantation of the coronary arteries. Now, of the 4 root replacement techniques, 3 exist. The one on the left is a root replacement with autologous inclusion. This is popularized by Peter Skillington from Australia. In the middle is the jacketed root replacement, also known as the Ross-Ross procedure. The autograft is placed within a Dacron graft to prevent dilatation. And on the right, which is the technique that I use, is the technique where the annulus is reinforced with Dacron, and the sinotubular junction is also reinforced with Dacron, keeping the autograft from dilating. And the single most important thing about the Ross procedure that is compelling to me and to most patients is the long-term survival benefit associated with a Ross procedure when compared to patients who have a prosthetic valve. And this is one study that was recently published showing that patients with a Ross procedure have restoration of survival that is comparable to the general population. You simply do not see this in patients who have aortic valve replacements or TAVI that receive a prosthetic valve. So the survival benefit is the most compelling reason to offer this. So I will show a video of the Ross procedure that I perform. Here we're through a full sternotomy or on cardiopulmonary bypass. Aorta is cross-clamped, cardioplegia is given. A low aortotomy is performed just above the sinotubular junction. The aorta is completely transected. And the valve is exposed with a total of 5 stitches, 3 at the commissures, 2 at the coronary arteries. Next, the aortic valve is excised. This is a bicuspid aortic valve with aortic stenosis. This cut is through the left-right commissure, and the valve is excised sharply. And this valve is grossly abnormal, maybe an old rheumatic valve. Next, the aortic annulus is sized in order to make sure the autograft and the annulus correspond. Next, the coronary arteries are mobilized. That's the left coronary artery. Next step is to mobilize the root. And at the same time, the pulmonary artery is mobilized in order to expose the pulmonary autograft, which leads to the harvesting of the pulmonary autograft. This is incision at the distal pulmonary artery, and the pulmonary artery is completely resected proximal to the bifurcation. The pulmonary valve is inspected, and the valve is good. It's a tri-leaflet aortic valve. The incision in the RVOT is identified from the inside, in a small right angle is used to identify that location. I use a vessel loop to mark that location so that we can make an incision externally. The valve is not visible externally. And the harvest proceeds with a cut towards the surgeon. And this cut is proceeding around the number 2 sinus. Proceeding around the number 2 sinus, you have to make sure you don't cut the tricuspid valve, which is to the right in the papillary muscles. And here is the number 1 sinus, which is on the intraventricular septum. The tissue can be divided, and at the intraventricular septum, we could stop for a second and then come around the lateral side of the autograft. And here, the coronary artery to the left coronary artery has to be avoided because it runs right along that side. Here, the muscle is divided sharply in order to avoid the branches of the left coronary artery. Next, the autograft can be lifted from the intraventricular septum, being sure not to injure the septal artery. And electric cautery can be used to finish this division here. And the autograft is harvested, and there is the septal artery visible in the middle. Now the autograft is inspected and the non-facing cusp is identified. Autograft is trimmed back to 2 to 3 millimeters below the valve leaflet insertion, following the scallops of the pulmonary valve on all 3 scallops. And you can see this valve looks very, very nice, appropriate for pulmonary artery translocation for the Ross procedure. Next, the autograft is sized to make sure there is no size mismatch, and the autograft implantation can be performed. Here again, identify the non-facing cusp, which will fit into the right coronary cusp of the LVOT. The stitches are interrupted 4-0 polypropylene sutures. These are deep LVOT implantation stitches. And the stitches on the autograft are placed right at the leaflet insertion so that no muscle is left in the circulation. It's just the valve in a deep LVOT configuration. Next, the autograft is inspected to make sure that no leaflets have perforated, no stitches have perforated the leaflets, and the valve is lowered into place. There are typically about 30 to 36 stitches, and all these have to be separately tied in a gentle fashion. Next, the coronary arteries are implanted. These are stay sutures in order to orient the top of the pulmonary valve. A knife is used to create a hole in the sinus. This is a hole punch, 4 millimeters in size. 6-0 polypropylene sutures are used to reimplant the coronary artery because the leaflet, because the tissue in the autograft is so delicate. After the left is implanted, then the right coronary artery is also implanted as a button. You do not need any outside reinforcement for these buttons. Next, the coronary buttons are inspected from the inside. They look fine. Homograft implantation, these are frozen cadaveric pulmonary valve with conduit. It is resected to appropriate length. Here's a pulmonary bifurcation, simply cut. You have to mark the anterior part of the homograft, which is identified by the ductus, and the homograft is also resected to size, and that's the anterior. These stitches are 5-0 polypropylene sutures. I do the distal anastomosis first. This suture line should be done so that there is no purse stringing of the homograft. The homograft is typically a 28 or 30 millimeter homograft, so it is an oversized homograft. The reason I do that is to minimize the risk of pulmonary stenosis. So even for a small person, we'll use a 28 millimeter homograft. This suture line is finished, and here is the proximal suture line of the homograft. This is done with a 4-0 polypropylene suture on the interventricular septum. The stitches have to avoid the branches of the left coronary artery. And after the suture line is completed, the right ventricle is de-aired. And finally, the Dacron graft that was used to replace the ascending aorta is sewn directly to the sinotubular junction of the pulmonary autograft with a 5-0 polypropylene suture. And you'll notice that the autograft isn't visible here because only 2 centimeters of the pulmonary root is required. So for valve choice, I think people talk mostly about the choice between mechanical and bioprosthesis, but I think for young patients, the Ross procedure should also be discussed. And I've already given you the indications for mechanical versus bioprosthesis, as well as a pulmonary autograft. The second decision that has to be made is valve approach. So whether you're going to do a TAVI or a full sternotomy. And this is also an important decision. And here, clinical practice guidelines can also guide our decision. This is the European guidelines on the top, American guidelines on the bottom. And again, this is based on age. So looking at these numbers, probably patients that are over 75 years old, TAVI is recommended. And the previous speakers have already discussed why TAVI is a great option for patients greater than 75 years old. But patients less than 65 years old, AVR is recommended per clinical practice guidelines. The in-between numbers there, we think of several things for clinical decision-making, and one is the risk group of the patient. Another is suitability for transfemoral access, and the last is life expectancy for the patient. I'd like to end by talking about minimally invasive cardiac surgery, and this is another option that oftentimes patients are not offered if they do not go to a comprehensive valve center. Clinical practice guidelines do not help us guide patients for minimally invasive valve surgery, but minimally invasive cardiac surgery has been associated with less blood transfusions, quicker recovery, and decreased length of stay, not to mention cosmesis. And there's 2 approaches for minimally invasive cardiac surgery. One is a mini sternotomy shown on the right, and the second is a mini thoracotomy, which is what I prefer. And the reason I prefer a mini thoracotomy approach is because there is no sternotomy. And if there is no sternotomy, there can be no sternal wound problems. And those include no sternal dehiscence, no sternal wound infections, and I think most importantly, no sternal precautions. So after a mini thoracotomy AVR you see on the left, I only require 2 weeks of exercise restriction. And this will be the last video I'll show you of a mini thoracotomy aortic valve replacement. I performed this in conjunction with an anesthesiologist, single lung ventilation. And starting with opening and cannulation, this is a horizontal skin incision to the right, typically between the second and third ribs. So this is the second inner space. That was the mammary vessel that was divided. So the rima, artery, and vein. Typically the third rib is disconnected from the sternal border, and that allows placement of a soft tissue retractor here. And a trick for the surgeons is to put the drop outside of the soft tissue retractor. And once the rigid sternal retractor is placed, pericardium can be seen below. And the goal of this incision is to have exposure of the mid-ascending aorta. So if you're looking at the right atrium, you are too low for this incision. If you're looking at the right atrium, then you're getting ready to do a mini mitral valve procedure. That would be too low. So this is the view that you should have with a mini thoracotomy AVR. Next is 3 stitches in the pericardium, avoiding the phrenic nerve. This is brought through the skin. The tool that was used now is the Carter-Thomason suture retractor, and those sutures can be brought in. Those puncture sites are invisible to the patient afterwards. A 4th stay suture is placed on the pericardium towards the left side. Sponge stick can be used, and the aorta can be cannulated directly through this incision. You do not need to do femoral arterial cannulation. And with retraction with a sponge stick goes between the aorta and the pulmonary artery. 2 horizontal mattress sutures with pledgets are placed in the distal ascending aorta. These are 4-0 polypropylene sutures, pledgets on either end. Only 4 bites are required. I use a Seldinger technique to place the arterial cannula. After serial dilatations, a femoral arterial cannula with multi-side holes are placed directly through the incision. Femoral venous cannula is placed also percutaneously. There is no cut down on the groin. And also after serial dilatations, a multi-side hole dedicated venous cannula is placed. And it's important to observe the venous cannula pass through the right atrium into the superior vena cava. Cannula is flushed and connected to the cardiopulmonary bypass circuit. After we commence cardiopulmonary bypass circuit, I take the time to place the first chest tube that will be used for post-operative drainage for CO2 insufflation. If needed, additional venous cannula can be placed in the SVC. Typically don't need to do that. Next is a aortic cross clamp, and this is a chitwood clamp placed through a separate stab incision. The top tongue should avoid the pulmonary artery, and the bottom tongue should also avoid the pulmonary artery and avoid the left atrial appendage. Once the clamp is on, a THI needle, anti-grade needle is placed at the site of the aortotomy, and I use a Del Nido cardioplasia, 1 shot for 60 minutes, which is enough time to complete an aortic valve replacement. So clamp times for this incision is really no more than it would be if it was a full sternotomy. And here is the aortotomy extending into the non-coronary sinus. Stay incisions are placed in order to expose the aorta. I put 3 stitches total, 1 in the left or right commissure, another in the right non-commissure. And here the valve is very well exposed through this mini incision. If need be, I give cardioplegia, particularly this aortic regurgitation, directly with coronary givers. The valve is excised. This valve is bicuspid aortic valve. And after the valve is totally excised, the annulus is debrided. All calcium is carefully collected, and the left ventricle is irrigated. Valve sizers are placed, and for this particular patient, a mechanical valve is placed, which I think is a great option for younger patients. These sutures are placed with long shafted instruments, and after the valve is seated into place, a autoknotter is used. There's only one in the market, core knot, and the valve is inspected and found to be well seated, and leaflets are mobile. After the valve is inspected, aortotomy is completed. This is a running 4-0 polypropylene suture. I do 2 layers. The heart is de-aired, and a root vent is replaced prior to taking off the aortic cross clamp. And there should be no bleeding from the aortotomy. Another trick for the surgeons is you can place a pacing, you could place a transvenous pacer on the heart, but do it before you come off cardiopulmonary bypass because it will be invisible after you do come off pump. Decannulation is simple. The venous cannula is closed with a 2-0 polypropylene suture. You do not need to do a cut down, manual pressure. The root vent is removed, as well as the aortic cannula. Cannulation site should look very good. You got pledgeted sutures there. And through the Chitwood site, I use another chest drain. So all holes in the body are utilized. And finally, I use a intercostal block. Recently, I've been using cryoanalgesia. So this is a cryo probe that is placed under thoracoscopic vision. And this cryo probe can freeze the intercostal bundle and give analgesia for up to several months. The rib is easily reapproximated with number 5 Merceline suture. This is a suture that's placed as a Kessler stitch, if you remember orthopedic surgery. Anesthesia will also place a paravertebral block at the end. So in summary, valve approach is not just TAVI or full sternotomy. There's also minimally invasive approaches. In between the hemisternotomy approach and the right thoracotomy approach, I prefer the right thoracotomy for reasons I've mentioned earlier. But the hemisternotomy approach does have its benefits. You can do a root enlargement through a hemisternotomy, as well as a full sternotomy will also have merit if there are other concomitant diseases that have to be addressed, including CABG, other valves, aortic replacement, or Mays procedure for valve for atrial fibrillation. So in conclusion, I'm going to end where I started. There's 2 decisions that have to be made for valve selection. One is valve choice, the other is valve approach. And I get the feeling over time, so I'll leave you quickly with my algorithm for valve selection, integrating everything I've talked about in this talk. So over 75 years old, TAVI is preferred. For patients who are 65 to 75, clinical decision has to be made. So either TAVI or a mini thoracotomy aortic valve replacement. Patients who are less than 65, in accordance with clinical practice guidelines, I prefer a mini thoracotomy approach. And for patients who are less than 50 years old, I think they either get a mini thoracotomy mechanical aortic valve or they get a Ross procedure. Thank you very much for your attention.
Thank you, Dr. Malaisrie, for your excellent talk. However, I'm not a surgeon, so I would like to invite Professor Wei and Professor Yida to make comments. They are also the masters of cardiac surgery and also the course director of this meeting, and give the closing remarks. Thank you very much.
Well, I'd like to say that, well, Dr. Malaisrie, but since I think you're a very skillful surgeon. Yeah. So, so good to see your demonstrations on, especially on the Rose procedure. Actually, Rose procedure hasn't been done by many surgeons, cardiac surgeons. I myself hasn't done that before. So, well, it's quite a very good technique. Okay. So, is there any other comment? Dr. Yeh also, yeah.
Professor Yeh, are you going to say something?
Hi, Dr. Mauricia, my friend. Excellent talk. And you're, as a professor, we say you're the excellent skillful surgeon. I think when I watch your Ross procedure, so it's like you make the Ross procedure very simple. Everybody can perform the procedure. Actually, this is a very complex procedure, but you make it really simple. And, I think you're the expert in the minimally invasive aortic valve procedure. And this, many years ago, you already give a great talk on this. And very impressive. I think, I think in the future, yes, I think a minimally invasive or less invasive, we should, performed in the young patient as for the speedy recovery, and sternotomy is an issue with the recovery, because it takes 3 months to heal in terms of bone healing. So I think that's great. But one question is about the Ross procedure. So I think that in the some expert is like perform lots of procedure. I think yes, I totally agree. This long-term survival is excellent and match the general population. How about right now? There's so many people in center now. They perform this Ross procedure, and the volume is relatively low. And what do you think this procedure should be performed in the more like a less center and have a dedicated Ross surgeon to perform this kind of procedure, rather than all the hospital, every surgeon or perform this kind of procedure? What are your comments and recommendations?
Doctor, I think that's an important point, because as with all procedures, there's a volume outcome relationship. So the more you do, the better you are at it. And for procedures such as TAVI, I perform TAVI as well. A lot of TAVIs are performed. So the learning curve can be very short for operators to get up and going, become experts with TAVI. So our center does 250 TAVIs. We have 6 physicians who can do that procedure. The Ross procedure also has a learning curve, and it is an even steeper learning curve. And the volumes are very low. So it takes a long time for any individual surgeon to become a master at the Ross procedure. Therefore, it is important that these procedures are regionalized. So, for instance, I would say in the island of Taiwan, probably only one surgeon would need to learn how to do the Ross procedure, and it would probably be Dr. Wei. But it is a very important point, because what should not happen is that the low volume operator does this case and cannot reproduce the safety that has been shown in high volume centers. So this procedure should be done with less than 1% operative risk.
Thank you so much. Thank you for your appointment. Okay, I would like to do that, but unfortunately, we don't have this sort of homograph for the pulmonary valves. Maybe we have to to do some kind of tissue valve for the pulmonary valve. Do you think it is possible?
Yeah, there's other alternatives. You can do a conduit and place a biologic valve inside a Dacron graft. That is also an option for you.
Okay. Yes. Thank you so much. And wondering about the fate of the pulmonary artery homograft. What's the fate of that?
Yeah, reinterventions for the homograft is also a concern. The homografts that we use now are made by a company called Artivion, previously known as Cryolife. And now they provide us with a decellularized pulmonary homograft. And the durability of the decellularized homograft appears to be even better than the older homografts. So the expectation now is probably less than 10% risk of reoperation for the homograft at 10 years.
Okay, thank you so much.
Okay, the meeting is come to the end. So I would like to invite the course directors, Professor Wei and Professor Hsieh, to give the closing remarks.
Okay, dear colleagues, before the closure of this convention, I'd like to thank all of you for your participation and contributions. With the rapid evolution of the medical industry, the treatment modalities has changed, especially in the field of valvular heart disease. It begins with aortic stenosis and propagates to the mitral valve. The speed of this evolution is so rapid that many cardiologists and cardiac surgeons can keep pace with it. The 2022 Taipei Valve Summit was a platform for distinguished experts to change experiences and, more importantly, provide a large amount of information for other clinicians to learn. There are always more than 10,000 medical professionals who visit this convention every year. People can even access the above materials after this meeting. I'm delighted that the cardiologists and the cardiac surgeons could work together for the patient's sake. We not only sit down to share decision-making, but also squat on the table in the same operating room. I thank our heart team members of Chengxin General Hospital for organizing this meeting. Doctors arranged the scientific program and did the operations. The perfusionist ran the pump and the video conference. And the nursing staff took care of other things. I'm proud that we didn't outsource our work to outside company. Finally, I would like to thank you again for attending the meeting. I sincerely hope everybody will take care of yourself and wish you every happiness in your work and the life. Dr. Hsieh would like, please, also say some words in our closing remarks.
Please turn on the microphone.
That's important. Thank you, remind me. And I think for me to say is a good morning, good afternoon, or good evening, depending on where you are. And dear Professor Wei and Professor Ying, and all the moderators, speakers, panelists, and all participants. And with everybody's support, we have had another outstanding valve summit, and the goal of the summit is completely accomplished. This summit have provided greatest opportunity for us to share experience, knowledge, opinions in the entire spectrum of heart valve disease and its management and interventions, as well as many new technologies, innovations for transcatheter mitral and tricuspid valve intervention. All the lectures are outstanding, I think, as a discussion are so fruitful. Of course, time never be sufficient for discussion in any kind of meeting. And the life cases are really educational. We have so many life cases, really enjoyed. I'm sure we have all benefited in some way from this summit. I believe that all of you have enjoyed outstanding lectures by world-leading cardiologists, cardiac surgeons, as well as the health professionals, and enjoy the fruit for discussions as there's many live cases transmitted from different hospital and centers during the past 2.5 days. I hope that what you have learned through the summit will help you in your future daily practice and eventually benefit our patient. I would like to give a big thanks to all the speakers from all over the world for your time and outstanding lectures, and share your expertise, experience, and invaluable knowledge, which will help everybody. I would also like to have a big thanks to our moderators, panelists for your questions, insights, and discussions. I wish to thank and congratulate the organizer, the Zhengxin General Hospital, and the organizing committee for the quality of organizing of this summit. I also like to thank the local supporter staff for your time, hard work, and a great help in this event. Finally, a big thanks to all our participants. We are looking forward to seeing you all in our next Valve Summit. Thanks and have a great day. Best wishes.
Okay, goodbye. Goodbye,
Thank
everybody.
you. Bye-bye.
Bye. Bye.
Thank you.